Very happy to welcome one of our more popular experts. His impressive resume includes heading up the Faculty of Child Psychology at the University of Ottawa prior to lecturing in psychiatry at Harvard for 7 years before moving to Vancouver. Most recently, he's become one of the leaders in the field of biofeedback and neurotherapy, which is the medical science of adjusting brain waves. In fact, many callers to our program have referred to him as a miracle worker, and that was including fellow doctors. Very lucky to have him in Vancouver and answering your questions today. It's Dr. Paul Swingle, and this is It's All in Your Head. Hello, Doctor.
Good morning.
Nice having you along as always. I know that your focus today is on attention deficit disorder, but as in all shows, we're always inviting everybody to call about any related question to brain activity.
Right.
Now, with ADD, it's one of those, almost like it became a buzzword. It became a craze. Anytime there was anything wrong with a child, it was because of ADD. What exactly is attention deficit disorder?
The first thing I think I want to emphasize is exactly what you said, that it's become a buzzword. It's a wastebasket diagnosis. Any child that's having difficulty for any reason, they're dumped into that diagnostic basket. Last show, if you recall, we discussed trauma in children, and very often we get children who have been exposed to emotionally traumatic circumstances, and they present like ADD. Giving them medications such as antipsychotics and methylphenidate, Ritalin, and so forth is just a serious mistake. In any event, to respond to your question, true ADD has very decided brain signatures. There are about 13 common forms that we see when we do a brain measurement. We measure the electrical activity coming from the brain, and we can look at areas of inefficiency in the way the brain's processing information. One form of ADD is inattentiveness, the daydreaming kid. Every time the teacher gets into something that's not stimulating, or if he's not feeling adequately stimulated, he's just drifting. He's out thinking about something else in la-la land. Another form of ADD is the little social butterfly, the child that's going around chatting, can't sit still, very affable, very sociable, but nonetheless a serious distraction in the class and just simply can't pay attention. And then we have other variations on that theme, the young child who is just super hyperactive and just simply can't sit still. It's hard for adults to really understand that for these children, it's actually painful to sit still. And the way we correct this is we just correct the brain functioning and make it efficient so that we eliminate the cause of the problem. Medicating these children is a serious abuse in my judgment.
Not that there's anything wrong with daydreaming or being social and all those kind of things, but I guess where you get most of your clients, your patients in is when the marks at school start to deteriorate. Is that fair to say?
Yes, daydreaming is a wonderful activity. I treat a lot of artists who have artistic block, and we teach them how to essentially daydream, how to have a lot of creative daydreaming types of periods. In any event, if the child is doing that when the child is supposed to be learning how to do mathematics, then we have a problem. So it's really the ability to shut it off that is the issue. It's very similar to when you want to go to sleep. You want to be able to turn the brain off. You don't want to be solving your financial problems when you're trying to go to sleep. Similarly, if you're in class, you want to be able to turn off the daydreaming to be able to focus.
And one of your key focuses on this program is talking about alternatives to medicine, and sometimes very powerful medicine. And I know that during the early part of the 90s, the big buzzword was Ritalin. Oh, if your kid's not paying attention in class, pop them on Ritalin, everything will be fine. But you're here to say that is a dangerous sort of assessment.
Yes, I think that's a terrible mistake to do that. Obviously, there's a place for medication when we have these very serious issues in which we have to get a child from place A to place B. And we work with a lot of physicians in terms of getting them on temporary stimulant medications and then as rapidly as possible titrate them off. People are not really aware of the serious dangers associated with Ritalin and some of the other stimulants, mainly because with all of the promotional activity associated with this, these areas are just not made known to the public. Ritalin, for example, decreases growth rate. We know that if a child's been taking Ritalin for 1 year at age 10, the average lack of growth is almost an inch, 4/5 of an an inch. Now, the popular notion is that the reason for this is the child's appetite is affected, and that if when they take holidays off the Ritalin, there'll be catch-up. The fact of the matter is it disrupts the growth hormone cycle. It's not simply a function of not eating. We have studies indicating that you have brain atrophy, that is smaller brain, associated with the use of stimulants. Tics and Tourette, common side effect associated with it. We get a lot of kids who come in who have developed a tic disorder, etc. Now there's recent work on cytogenetic effects, which is a change in the chromosomal structure that's related to cancer associated with methylphenidate. And one of the things that we've known for a long time is it affects myocardial tissue, which is the tissue surrounding the heart. So if you consider all of those things, medicating a child with something like methylphenidate to make your life a little easier just doesn't make sense. And I think one of the compelling reasons that we're using methylphenidate is to make it easier for the teachers and the parents. Grossly inappropriate use of that medication. We haven't talked about the antipsychotics they're using with kids. We'll get to that a little later.
So there's kind of like a double whammy. Number one, they may be misdiagnosed as having attention deficit disorder. And then number two, they may be taking medication that they don't even need to take for the wrong thing.
Absolutely.
What we're talking about is a scientific process called neurotherapy. I'm sure a lot of people don't know what that is because I certainly didn't. You know, and a caller in our last show had a really good question. We were talking about adjusting brain waves with really small pulses of electricity, and he said, well, isn't that sort of like what they did to Mr. McMurphy in One Flew Over the Cuckoo's Nest? And it's a totally different thing than electroshock therapy. Maybe you can explain what neurotherapy really is.
Yes, there are a number of different procedures that we use in neurotherapy. Basically, what we're doing is encouraging the brain, nudging the brain, training the brain to move into more normative functional patterns. What we do is as I indicated, we do a brain map. We look at the electrical activity coming from the brain, and we look to see if there are areas of inefficiency. We know what the brain should look like, and if we get departures from that, then we have some idea of areas in which the brain's not functioning appropriately or normatively. The way that's corrected is referred to as neurotherapy. And there are basically three general classes of treatment. The first is referred to as neurofeedback. That's the one that most listeners are probably familiar with. We set it up so that when the brain is doing what we want it to do, the client hears a tone or sees something move on the computer screen. Now we can make that like a game so that if it's a young child, they're actually playing a video game with their brain. When the brain's doing what we want it to do, Pac-Man runs across the screen and gobbles up dots and so forth. The second class of treatments are the brain drivers. My clinic is number one in North America in the development of these, and they're now being used by a number of clinics around the world. But basically, with brain driving, we measure a particular aspect of brain functioning, and based on that measurement, we stimulate with light and sound. For children, for adults, we add microamperage stimulation, EMF fields, and so forth to nudge the brain into more normative functioning. So, for example, if we're trying to decrease a waveform, as soon as that waveform gets too high, then we stimulate with light to drive it back down. Now, the advantage of that is we can be stimulating an area of the brain responsible for a particular activity like reading, for example, and we can keep that area of the brain in normative functional range while the child is reading. We're working with one of our remedial people. She does remarkable work in terms of being able to get children to read after a few sessions.
Well, that's what neurotherapy biofeedback is, and we're going to talk a lot more about it because it's not just for ADD. That's only one of the many, many symptoms that can be dealt with. And by the way, Dr. Swingle works at Swingle and Associates. The website address is drswingle.com, and the telephone number is 608-0444, 608-0444. We'll give that number out throughout the course of the show. If you have a question for the doctor, maybe perhaps relating to your child or perhaps to your own issues, we had a ton of calls, very interesting calls the last time you were on. We're going to talk more with Dr. Paul Swingle, and this is It's All in Your Head. You have a lot of children that come to your clinic. The first thing that you do when a parent comes and brings a child to your clinic is what?
The first thing that we do is a brain assessment. We look at usually about 6 critical areas in the brain. And as I indicated, we're looking for areas of inefficiency in the way the brain is functioning. I talk directly to the child in terms of showing them the areas where the brain's really working extremely well and areas in which the brain is working outside of normative ranges. And I ask the child if they experience the kinds of conditions that would be associated from those departures from normative functioning. Children like this approach because usually they're sitting there while their parents are telling a tale of woe. It's very different when I address the child directly, show them what their brain looks like, and ask them to comment on their own behavior relative to the departures that we're seeing in the brain. And they're very excited about playing video games with their brain. We also play around with other things. We can make electric trains stop and start with the brain function and so forth. The good news is once the brain is into normative range, once it's fixed, it's fixed. We pay a lot of attention to stability, so when we're finished, we'll see the child at 3-month intervals for a couple of times, and then 6 months after that, just to make sure it's stable, because as I said, once it's fixed, it's fixed.
Perhaps you have a child or a grandchild that displays what is commonly thought of as attention deficit disorder. But how often does somebody come in, a parent or a grandparent, come in with a child that thinks it's ADD when in fact it's actually something perhaps even more serious?
It's usually the other way around. We have individuals come in and schools have indicated that this child has ADD or ADHD and they want the child medicated. And they always recommend that they put the child on some sort of mind-active drug. Generally speaking, we find that any departures we get are relatively minor, and what we're dealing with is boisterous children's behavior. What really disturbs me is that we're medicating normal children's behavior. And we can tell that immediately. If we do a brain map, we know whether we're dealing with a real situation in which there's a brain inefficiency or whether this is simply people who are impatient with the robust behavior of a child. Having said that, I think this might be a good time to talk about the disturbing increase in the use of antipsychotics with children. Antipsychotics, as the name implies, are drugs that were developed for the treatment of conditions like schizophrenia. We find that starting in the mid-90s, physicians were starting to prescribe antipsychotics for the behavioral problems with children. That's a very, very serious misuse of that medication, in my judgment. From the mid-90s to 2002, there was a 5-fold increase in the use of antipsychotics with children, so that by mid-1900s, 40 out of 1,000 children, if you can believe that number, 40 out of 1,000 children were on antipsychotic medication. Since that time, it's jumped 80% over the past 4 years. So what we have is a situation in which you're using a powerful medication to control a behavioral issue in a child. Now, if that doesn't strike you or me as absolutely absurd, I don't know what would be absurd. The whole notion of medicating to control the behavior of a child is, in my judgment, absolutely unacceptable. They may not respond to neurotherapy in that kind of condition. You know, you may have some minor issues. They're having some difficulty with paying attention, for example, and you might correct that. But the major issue there is the behavioral component, and we do a lot of work with the parent in terms of showing them how to modify the behavior of the child so that we're helping them with parenting skills. Medicating that problem is a gross misuse of that medication.
Let's go to Karen on the line. Karen has a question about medication. Hi, Karen.
Yes, hi. My son is on Concerta, and I wanted to find out how different that is from Ritalin.
The jury is not in yet. The reason for that, of course, is Concerta is a much newer medication. It has the same kind of stimulant properties. My own feeling is that it undoubtedly would share a lot of the same problems you would have with methylphenidate.
What kind of symptoms does your son have, Karen?
Oh, well, in school, he has behavior. He's the type that, is chatting all the time, and a teacher will tell him, sit down, don't talk, you're disrupting the class. He doesn't do it. He just, he would keep doing it. And even at home, he just doesn't listen. He's always, when I tell him, when he's at the table to sit down to eat, he's up and he's playing with the cat or he's doing this. He just can't concentrate. He plays baseball, and when he's on his medication, he hits home runs and he does really well. And then during the summer when he was off it, because I only put him on it, during school, he went into summer ball, and the coach was saying, gee, Joey, big difference in what's wrong with him. When he was, the other ball, he was really well. He was on medication, and he said, oh, well, can you put him back on it? And the day I put him back on it, he started hitting home runs again, and I noticed a big difference.
Absolutely. What you're doing is you're providing stimulation to the brain. Instead of your child self-stimming, which is bouncing around, chatting with everybody, and being distracted, you're stimulating the brain with a chemical so that he's quieter, in a sense, and able to focus more. My guess is that he has a particular type of ADD in which there's an excess of a particular waveform in the front part of the brain, referred to as alpha frequency. Alpha frequency is 8 to 12 cycles a second, and when you have too much in the front part of the brain, what it's usually associated with is chattiness, bouncing around, very, very sociable child, inability to sit still, problems with planning, organizing, sequencing, and following through and things.
Oh, it sounds just like him.
You know, I've seen thousands of these kids, and from your description, you know, I could bet the farm that's what we're going to find on the brain map.
And the other thing, he's deaf. Have you ever worked with deaf kids?
Oh, yes. That's another problem. If he's deaf, then he has a huge deficit in stimulation, so that he has a double whammy.
Okay, well, I will make an appointment to come see you.
Thanks a lot, Karen. The number at Dr. Swingle's clinic is 604-608-0444, and the website address, by the way, is drswingle.com, and Swingle is spelled Swingle, S-W-I-N-G-L-E, drswingle.com. Get to Vilma's call in just a second. You're listening to Experts on Call with Dr. Paul Swingle, and it's all in your head. We're talking about ADD and other learning disabilities, but if you have a question about anything related to the brain, emotional trauma, anything like that, depression, let's go to Vilma. Hi, Vilma. You're on with Dr. Paul Swingle, and it's all in your head.
Good morning, Dr. Swingle. I have a question. My daughter was born premature, and she has a CP, and now that she's a teenager, she become more, her emotion become more severe, that she's talking at night, she couldn't sleep, and so she's being argumentative. So the doctor diagnosed her as a borderline personality disorder, and they put her on Risperdal to calm her down, and put her in the Zoloft for her depression, as he said. Now when we check into, or we meet into a pediatrician, he said that she could be taken off the Risperdal, but we have to deal with her behavior. Is there something you could do about this?
Yes, we see a lot of people with personality disorders and depression, sleep problems. There is a behavioral component associated with treating these things in addition to correcting the brain.
So, if you could be taken off the Risperdal and the behavior could be manageable?
Yes, the focus of what we would be doing is to correct the brain functioning and then work with your daughter to help her with self-regulation of emotional states once the brain has been normalized.
So in this case, I have to book an appointment to see you then?
That's right. The first step is a brain assessment to see what we're dealing with, what areas of the brain are causing the difficulty.
How old is your daughter, did you say, Vilma?
It's 15 and a half.
15 and a half.
Well, we have a lot of issues there. We're dealing with adolescents. In our present cultural climate, dealing with adolescents is very, very problematic.
Yes, it's kind of like, because she's a teenager, they said it is normal. But for her not being focusing, she had to be like constant prompting to stay in task. So that's why they put her into medication so that she can live, normal day-to-day life. But in the medication, there's a lot of side effects.
Yes, very definitely.
Hey, thanks for the call, Vilma. We appreciate it. Thanks for being on with Dr. Paul Swingle. Here's the clinic number. It's 604-608-0444, 608-0444. Your daughter would go in, have an initial assessment, which includes, really, it's about 6 minutes. All in all, you do a little bit of reading. And what else? I can't remember. It's been so long now since I've been in. What happens in the initial assessment?
If we're doing a basic assessment, what we do is have you open and close your eyes at various times, ask you to read something. Then we play a sound, a harmonic, to see if you're responsive to harmonics so that we can use those in the treatment. The actual recording time is 6.5 minutes. It takes a bit longer than that because we're moving electrodes around and so forth. If you came in with a brain injury, for example, if it was post-accident or if you had epilepsy or a stroke or something of that nature, we would go right to a full brain map. There we put a cap over your head and measure all 19 sites, and then the data that comes from those measurements are run through a database so that we are looking at many, many, many statistical comparisons to determine where the areas of inefficiency are. For example, a traumatic brain injury, it may not be a certain area of the brain that's not functioning efficiently. It may be the way a brain is talking to itself, so you may have site-to-site communication that's problematic, and a full brain mat would pick that up.
I mean, there's so many different things and so many different treatments that your clinic offers. Have you ever sat down and counted them all? How many issues you can treat?
Well, when we do the public lecture, I have a slide that I put up, and the list is very long indeed. Fibromyalgia, sleep problems, depression, all of the anxiety conditions and so forth. By the way, when we're talking about ADD and learning problems in children, one of the things that we often run into is childhood depression, so that it's not really ADD, it's a depressed mood state. Now, in children, very often it doesn't manifest as frank sadness, so that it doesn't look like what the adult would usually define as depression. It presents as lack of interest, poor motivation, disinterest in things, inability to focus, not because of ADD, but because of the conditions associated with lack of motivation. That can be identified when we do the initial brain assessment. We can see whether it's depression that we're dealing with or whether we're dealing with one of the forms of ADD. Depression itself has a number of different signatures, so we can correct the right type of depression.
Let's just take a quick break here, and then we'll go to the phones. I think we have Cheryl on the line. You're listening to Dr. Paul Swingle. This is Experts on Call. It's all in your head. And Dr. Swingle's number is 604-608-0444. And one of the things that I've noticed over the course of knowing you, Dr. Paul, is that there's a particular emphasis towards children. You being a dad, I guess, and a grandfather, if I'm not mistaken, maybe part of the reason for that?
Yes. When neurotherapy was first developed, one of the first applications was ADD, so that you get a lot of clients who are children simply because of that, the legacy of successful treatment of learning disorders and ADD and so forth. The other thing, of course, is if you can make these kinds of changes and normalize brain activity, you change a child's life. When you see the changes that take place in these children, it's enormously satisfying. The same sort of thing with the elderly, too, by the way, when they're brought in on all of these medications and you get them off the medication, the eyes light up.
Well, we'll give some more examples of how you've helped a lot of children out, and you have some great stories about that. But let's get to Cheryl. Cheryl, thanks for waiting. You're on with Dr. Paul Swingle, and this is It's All in Your Head.
First thing I want to say is I have to give thanks to many areas, especially to Dr. Swingle, for coming out of retirement here in Vancouver. He came here to retire, to enjoy his life, and he just found a need here, and he's just been helping everybody. And I'm so grateful because, as he knows, he's pretty well saved my daughter's life, because before she went to see him, there was no hope, really. I mean, I didn't even know if she could hold down a waitressing job. And now she's got friends. She never had friends before. She's got a life. She's doing okay in school. She's got to make up because there's quite a few years that she was behind, but she's doing awesome. You wouldn't recognize her. And he also did the same thing for me. He exercised my mean muscle, so now I don't take things so personally, and I stick up for myself, and then I let go of things right away. He's done wonders. Now he's working on my husband.
Are you saying I made you meaner?
I was welcoming that for everybody before, and I was just a walking wound.
How about assertive, not meaner?
Or assertive. Well, even being able to stick up for myself, and people see it as being not nice. All of a sudden, people are starting to respect me because they know that they can't get away with what they did before.
Cheryl, what brought your daughter in to see Dr. Swingle?
A friend of mine said that it can help with alcoholism. So a lot of people from AA go there. And then when he was in there, he found out that they treat ADD and ADHD and told me about it. So I ran down there with my daughter and had the map. And we just trusted because we didn't know anybody who had been cured by him. As a family, we just thought, oh, God, can this be the ticket, right? We didn't want to do drugs or anything else, and I've spent years and years of painful tears and working with my daughter with tutors and doing homework every night. 15 minutes of homework for a normal child ended up being 3 hours for her, and we had things down, and she lost it as fast as she got it. It was absolute nightmare. We had no hope for her at all. She had ADD.
And how long before you noticed a difference?
It was a subtle transition, but where we noticed biggest difference was when we switched schools for her, because her old school saw all her friends, all her teachers saw her as a different person. And as you know, it's hard to become somebody else when everybody else wants to keep you stuck there. So when we switched her to a new school and nobody knew her, all of a sudden she had more friends in 1 week than she did in her entire life. She is friends with every social group. She's not just stuck in the losers group anymore. She's being acknowledged. The teachers love her, all because she is a different person now. She keeps saying stuff, and I go, well, why do you think that is? Because she's different. She's not the same kid. We used to drive down the street, and we'd see friends from her school, and I'm very outgoing, and I waved. She would hide. She would hide below the window.
Interesting. Hey, well, Cheryl, thanks so much for sharing your story with us. I really do appreciate that. And well, it's a great story, and you have so many like that. I mean, I couldn't believe when I went to your clinic how many young people there were there. I mean, it was crawling with kids, and there was a lot of kids who were acting out quite a bit. You mentioned before that that's part of the treatment.
Yes. We focus a lot on helping the parents with the behavioral problems associated with the child. Sometimes there's an area of the brain that's just not adequately functioning, and the child's behavior problems can't be really addressed until you normalize the brain function. That's certainly true with the autistic spectrum kids that we see. There are whole areas of the brain that really have to be corrected so that they're amenable to some of the behavioral treatments that are necessary for the child.
Let's go to Lori.
Hi, I have several questions. One is, I have a friend, I'm moving back to the Okanagan. I have a friend there whose granddaughter has AD, and she's, done the whole thing tutoring for all through her elementary years, and she's probably 12 or 13. How long would it take if she came from there to treat her? Like if she'd probably come in the summertime and spend several weeks?
We treat in a variety of different fashions. For example, we have people fly in from all over the world, and they might spend a month with us. If you lived right around the corner, the ideal situation is once or twice a week, and then at some point every 2 weeks, then once a month, and so forth. We have a lot of people coming from the interior, and what they do is they come down initially for a week or two of intensive treatment, and then they come down infrequently, perhaps once a month for a couple of days. A lot of it depends on what we're dealing with, what's the nature of the problem.
Okay, well, I'll get her to look at your website. The other question is, you mentioned addictions. Does that include all addictions, like hard drug addictions, as well as smoking or alcohol or whatever?
Oh, yes. We deal with gambling, sex addictions, all of the drugs, prescription medication, alcohol. One of the more difficult of the addictions we deal with is smoking.
And also you help with, I understand, tinnitus and sleep problems.
Tinnitus is an unusual kind of thing. It depends on what type of tinnitus we're dealing with. Some of them respond very quickly. Some of them respond very grudgingly.
Thanks for your call, Lori. Here's the telephone number. It's 604-608-0444. Talking a lot today about attention deficit disorder, but we were talking about anything you like to if you have a question. Cheryl, a few moments ago, you just hear in her voice how relieved, happy, and how important it was for her daughter to get onto the straight and narrow, as it were, after having been diagnosed with ADD, and I guess that's why you enjoy doing your job.
Absolutely. I have to stop fooling with clients that I'm going to make them meaner. Actually, there's an area in the brain that if it's underactive, people are very passive, and that's what she meant, being walked over, so we just strengthen that a bit.
Let's go to Lori. And Lori's got a question about head injury. Thanks for waiting, Lori. You're on with Dr. Paul Swingle.
Hi, Dr. Swingle. As bizarre as this is, my brother is heading in to have electrodes put into his brain for dystonia and a shake in his arm. That accident was 20 years ago. And as you know from head injury patients, it's probably taken 20 years to get his thought process to even be somewhat normal. In the last 10 years, the dystonia and the shake has gotten so bad that, of course, he can't work. And the fact that he's going in to have these in tomorrow, we are hopeful that this will help with the dystonia in his neck and the shake. My next question is that mentally he has some difficulties in making decisions and all of those kinds of things that, we take as normal. Is there something that you can do with him that would help parts of the brain that don't work to take over new parts of the brain? We compare him to what he was, and it's not the same person. Or do we just fix the physical part, hopefully? Not a guarantee, of course. You said something about head injury patients or brain injured patients.
There's been some remarkable advances in neurotherapy treatment for traumatic brain injury. With traumatic brain injury, you get a lot of things similar to what you're describing with your brother. You get seizure kinds of disorders, you get dystonia, always emotional changes, because no matter how you're hit, the front part of the brain is always implicated because of the way the brain sits in the cranial vault. What we do is we do a full brain map with these folks and look at the areas that are not functioning properly. And as I indicated earlier, one of the central things in traumatic brain injury is the way the brain's talking to itself. So there are specific treatments that we use for the physical aspect, that is the shaking and the dystonia and so forth, and then other treatments that we do for the intellectual cognitive function. We often combine this with restraint therapy. After we stimulate particular areas of the brain, we restrain the more functional side, forcing the use of the affected side, and there are other areas of the brain that will light up, so to speak, and take over the function of the damaged areas. There are several centers, including ours, that are very good at doing this. Dr. Bruckner at the University of Miami has an international reputation for handling some of these things. We do a lot of it right here in Vancouver as well.
Well, best of luck with your brother, Lori, and thanks for the phone call. Robin's been waiting for quite some time. Thanks for waiting so long. Robin, you're on with Dr. Paul Swingle.
Yes, hi. Good morning, Dr. Swingle. I just wanted to inquire. I grew up with having dyslexia, not that I was diagnosed till I was into my 40s, actually. I mean, I was aware of it, I'm sure, at one level. And, you know, obviously ADD was, again, attached to that. I had some traumatic issues also as a child. I was just wondering, I guess depression is sort of the outcome.
Yes, we treat all of the conditions that you mentioned, dyslexia, ADD, and depression. Now, there are some depression conditions that are really what we call reactive depression. That is, you've been through a lot of traumatic situations. You develop depression based on your experience. There are other forms of depression that are genetically based or at least physiological in nature. All of those are correctable. You correct the neurology of it and then deal with the other in psychotherapeutic or behavioral fashion.
My son also was killed when he was 16, and I feel ever since then that, you know, I'm indecisive. All sorts of funny symptoms that seem that I used to be able to do just fine are still there.
Yes, your brain is probably carrying what we call a trauma signature. When the brain is carrying that signature, what happens, people have a lot of difficulty with emotional regulation, a lot of problems with decision-making in particular. What we do is we correct the neurology of that and help you process the trauma, even if it's a long-standing trauma.
Well, it sounds very hopeful. You would initially come in for a consult then? Is that how it works?
Come in for initial brain assessment so we see what the brain is telling us. We can work out the treatment protocol based on what the brain map is telling us.
Thanks so much for your call, Robin. I really appreciate it. Obviously, you know, that's going to be a traumatic event, and I know you see a lot of people with the exact same kind of thing, a traumatic family situation leads to depression.
That's right.
Let's go to Janice. Janice, thanks for waiting. You're on with Dr. Paul Swingle.
Hi, I have a question. Several years ago, I was diagnosed being bipolar, and that seems to be perfectly under control with folic acid and a bunch of vitamins, right? But I had a car accident in 2001, then had the brain scans and whatnot after that, and the neurologist sort of concluded that there were quite a few holes in the area on my brain that he was seeing, and there was really nothing he could do about it, and I should come back in a year, and then, of course, that hasn't happened. Now, since then, I seem to be getting really quite confused. Oh, and he sort of attributed this to being mini strokes that could have happened at the accident, but they don't know for sure. And so what's happening, and it's quite odd, I seem to be mixing up words. Like instead of saying kumquat, I'll say rumquat, and instead of pyramid, I'll say primrad, and it's just bizarre. And now I've noticed, well, for example, I went to pay a bill the other day on 2 different American Express accounts, right? Completely wrote the wrong number down, wrote it to the wrong account, even though I was looking right at it, like the check that I wrote out, and just mixed it up completely and didn't mix up the numbers, just made up numbers. It was really weird. And so now I'm starting to worry that, well, maybe I should go back and see this neurologist. And I don't really think there's much he can even do. And then my family doctor said neurologists in my neighborhood have this new machine at the hospital, and none of them seem to be able to read it. And as a result, all of her patients seem to have holes in their brain. She had sort of a chuckle out of it and said, well, you know, don't really worry about it. It's nothing that they're going to be able to fix anyway. So what do I do? Like, is your program something that could help?
Absolutely. First of all, you don't have holes in the brain. What that's showing is areas in which there's hypoperfusion, that is low blood flow, and it turns out dark on the scans. Neurotherapy sounds to me as though it'd be right down your alley. A lot of what you're reporting seems to be problems with the prefrontal cortex. What we would do is a full brain map in this case and determine the areas of inefficiency and then use neurotherapy to correct it. Been a huge advance in neurotherapy treatment for a head injury, even long past the time of the actual accident.
Janice, thanks so much for calling. We have time for one very quick call from Patricia. Sorry, we just don't have a lot of time, but you have a great question. Patricia, go ahead. You're on with Dr. Paul Swingle.
Good morning. Thank you for taking my call. Dr. Swingle, I'm 57 years old, and I know you've been talking about kids and some adults. And just quickly, background over the years, bipolar, alcoholism, 16 years sober, no mania since postmenopause. I have a really severe nicotine addiction and ADHD and dyslexia. And as I get older, it's getting worse, especially the ADHD, dyslexia.
Yes.
And I'm wondering whether that constellation can be treated.
Yes, it can. One of the things that we find with some of these conditions is they start to get worse as we get older, so that you're having age-related declines in function, which are correctable in and of themselves, by the way.
That's all the time we have. I mean, you've just crammed in a whole bunch of phone calls, but there is help for you, Patricia. Here's the telephone number, 604-608-0444. That's 608-0444. Dr. Swingle's clinic, Swingle & Associates on Melville Street in Vancouver. His website, drswingle.com. Swingle, by the way, spelled S-W-I-N-G-L-E, drswingle.com. Thanks for all the advice and all the good information again today.
Okay, we'll see you next month.